Well, folks, I was doing a video and I was talking about the low fat diet. I don't have too high of an opinion about that diet for various reasons. And Dr. Tony Hampton, who I interviewed a while back, contacted me and said he'd like to share a little bit about it, what he's discovered, and also related to type 1 diabetics. So, Dr. Tony, welcome to Beat Diabetes.
I am happy to be back and excited. We're recording around a day before Thanksgiving, so I tell you, it's a couple of days off for the doctor. It's very unusual, so happy to join you again.
Well, I have to point out to our viewers that Dr. Tony is a little different from a lot of the YouTube doctors. A lot of them, all they do is YouTube. And Tony, you see patients all day, most days. I think you told me you see about 25 patients a day. Is that right?
Yeah, I do. It's somewhere between 20 on a short day up to 30 and busy, busy, busy. So the moment I walk through the door, I have to get there early just to have an opportunity to breathe. So I'll get there maybe an hour and a half early, settle down, look at the schedule, figure out what we have to do. But yeah, once we get started, and I'm a medical director. So a lot of times between patients, there's questions from other doctors. Can they do this? How to network that? So it's very busy, but it's kind of a marathon, but it's like a sprint the whole time.
Well, just hearing all that you're doing kind of tires me out and makes me wonder why in the world would you even bother with YouTube? But it's good that you do. I know you're blessing a lot of people. So
it's really just reaching more people, 25 people versus, so that's what it's all about. And I just felt that was Dr. Kim Berry is the one who inspired me to get off the clinic path only and do a little bit of the video work. Yeah.
Okay, well, good for him and good for you.
Absolutely.
So one of the questions I want to ask was about a type 1 diabetic. A lot of times they're not so much encouraged to get their A1C very low. In my opinion, there's just no reason why we can't get below pre-diabetic, which would be below 5.7. What do you think, and how does your opinion differ from, say, the ADA?
Unfortunately, most large health systems follow the dietary guidelines and they follow the guidance of the American Diabetes Association. Now they're getting better, but the problem is their expectations don't meet mine. So a little while ago, I looked at a registry. So there is a registry for type 1 diabetics. It's called the Type 1 Diabetic Exchange Clinic Registry. And with that registry, the last time I looked at it, and it was going back to data from 2015, 2016, it showed that the average type 1 diabetic has an A1C of 8.4. Now, that's a problem because that means their blood sugars are averaging over 200. So when you combine that reality with the fact that for the ADA, they're saying, let's get your blood sugars in the 7 A1C range. I just think that's not acceptable because I think that it leads to the potential that you're going to have complications. So I think that the recommendations that are considered standards should apply to all humans. All humans should have a normal blood sugar, and that's why I don't agree with those expectations.
Yeah, well, it seems like from what I have heard, so many doctors are fearful about the hypos that you can get. It seems like there's a big difference between getting your glucose levels down with diet, and if you're a type 1, the proper amount of insulin, which is going to be less, or just doing it by just injecting more and more insulin and forgetting about your diet. That makes a big difference about how you do it, doesn't it?
Yeah, it does. You have to look at multiple factors. And if you just focus on just the medicine and you become medicine centric, you'll never get your blood sugars under control. In fact, that's kind of why your video intrigued me, because most of the management of a type 1 diabetic is, medicine centric. That's how our endocrinologists think. That's how our primary care doctors think. And what happens is if you just rely on your insulin, you will never have the kind of control that a normal person would expect to have. So I just think that there are other, we have to look at the big picture. And some of that includes, your stress level and other factors that will affect your blood sugar. So the key is, let's think about all of these factors instead of just focusing on whether or not I'm taking my medicine properly.
Yeah, if you didn't know better, and I do know better, but if you didn't know any better, you would suppose that the type 1 diabetic would be the perfect case where you could control your blood sugar almost exactly the way you wanted it. Because if I'm going to eat a big meal with a big old helping of mac and cheese and a huge chunk of bread and a dessert, I'll just simply take more insulin. And if I'm going to have a steak and a salad, I'll take less. Why can't you just control it that way? Why does that just not work? And I know it doesn't, but tell us why it doesn't.
Yeah, it's not intuitive, right? Because you think that you can simply literally just use your insulin as the key, right? And that's not really the way it works, because insulin is a very, very, very different animal if it comes from the drug companies, right? So let's think about that. So if you're using pharmaceutical insulin, it's not going to be able to like duplicate the insulin that your pancreas makes naturally. So what happens is there's something called glycemic variability, right? And what that means is that your sugar is up and down, up and down. So that's variability. So when you use the industry version of insulin, there's going to be more variability, meaning that because you're going to be chasing, someone's going to tell you, hey, if you have a lot of carbs in your diet, just chase it with a lot of insulin. So that means that it's going to probably it's going to overshoot most of the time, because there's kind of a mismatch between the insulin that you are, you're injecting versus how your nutrients are absorbed. How effective is your stomach emptying? Have you been a type 1 diabetic for years, and now you have what we call diabetic gastroparesis, where the stomach's not functioning properly? So that's the kind of stuff you have to think about. You also have to think about the preparation itself. If you get insulin from one pharmacy or one company versus insulin from another, it may not be exactly the same in terms of how it functions in your body. And the problem with insulin that's exogenous or from outside the body, not from your pancreas, is that it's going to lower your blood sugar no matter what, right? So your endogenous insulin working with other hormones like glucagon and inulin, those hormones, they kind of work in a partnership. So when you use exogenous insulin, you lose complete control. So and even how your body produces many people are aware that the pancreas can produce glucose from the liver can produce glucose, and the pancreas can produce glucagon from the alpha cells, and how they interact with insulin is different. So if you have insulin made from the pancreas, it actually does a better job of inhibiting glucose production in the liver. So all of these factors equal, you better be very careful if you're a type 1 diabetic who has to use pharmaceutical insulin, which is not the pancreas insulin, because there's going to be all these factors you have to consider. And so that's kind of how I see it, and why you have to be more careful if you're a type 1 diabetic.
Yeah, I would agree with that for sure. I want to share a comment that was left by one of our viewers and get your reply to, your comment on his comment. Okay. This man is the father of a daughter who's a type 1 diabetic. She became type 1 at the age of 7. And he almost immediately read Dr. Richard Bernstein's book about keeping your carbs low so you don't have to give so much insulin. And he began to use that with his 7-year-old daughter. And lo and behold, it worked well. He said for many years, you wouldn't even be able to tell she was a diabetic if you just looked at her numbers. Her numbers were in such good control. But about 15 years later, after 15 good years of control, through a low-carb diet and giving the proper amount of insulin, she got an insulin pump hooked up to her that would automatically release insulin as needed. And again, if you didn't know any better, you would think, well, that's just perfect. I mean, you take more carbs, the pump knows it, and it releases more insulin. You take less carbs, it releases less. And she was told, now that you've got this pump, you can pretty much eat whatever you like. He said she did, and her A1C and her glucose levels were totally out of control. And so, again, it doesn't seem like that should be the case, but it sure was for her.
Well, again, you're going to have glycemic variability if you have a model where you either are saying, I'm just going to chase the high sugars with medicine, insulin, and it's going to be, again, it's high because you consumed the wrong medicine, then it's going to plummet, and then you're going to keep chasing it up and down. That's not the model we want to use. And in the previous video that kind of triggered this conversation, you talked about, how a high fat, a low fat, high carb diet was not a good idea. And to be honest with you, it speaks to this question because, we started this, I think, in the 1950s with Ansel Keys and the American Heart Association without good evidence. It was a hypothesis that, a low fat diet seems to reduce the risk of cardiovascular disease. The problem with that is that we know that, if low-fat diets based on that hypothesis reduce cardiovascular disease, and we know diabetes increase your risk for cardiovascular disease, they then hypothesized that a low-fat diet was the best diet to prevent cardiovascular disease in diabetics. But the problem is, as illustrated with that last example, you're going to eat a diet high in carbs, and then you're going to chase it with insulin, and that's going to increase that glycemic variability, right? And that's going to then increase your risk for all the complications that occur. Because just having, even if your A1C seems reasonable, all those peaks and troughs are going to really end up harming you. So what would be more logical if in a person who can't tolerate dietary carbs is to have a diet where you reduce dietary carbs, and that way you reduce the variability so that little up and down is more narrow, which will then decrease hypoglycemia and it'll decrease hyperglycemia. That's a more logical approach, and it's the approach that anybody should follow. So rather you're using the insulin pump or using exogenous insulin, with the, the injections, it just makes more sense to have a diet. And that's the big message that I wanted to share, is that if you tighten the range and you don't have a lot of variability of your blood sugar, it's easier to then manage your blood sugar because you're not chasing those super high numbers. And then when you give insulin, you take less of it. Therefore, the chances of hypoglycemia is much less. So I just think that I love technology. I'm happy they have technology. But I think that if we rely on technology and not common sense says, rid yourself of the poison, which are the excessive carbs, and then you won't really need to take as much insulin as you did previously.
Yeah. So what about counting carbs? Is that necessary? Is it important? Can you use that to gauge, can a type 1 use that to gauge how much insulin to take? What do you think about that?
Well, it's definitely important because you do want to, particularly for my new patients. So when I am in front of a patient at clinic, I think they should count carbs, mostly because they don't know what they don't know. So if they don't know that Raisin Bran has about 46 carbs, then they will think that that's a healthy option. So I think people should count to understand where they stand. The problem is, and whether you're a type 1 or a type 2, is that when you look at labels, right, how do you really know how many carbs are in that food? So, and this is the part. So the first flaw with our current system is that the FDA allows for a 20% margin of error on nutrition labels. I want to pause and have you think about that, Dennis. 20%. So that means that if I have a 20 carb number on a label, I'm allowed to assume that that could be 16 or 24. And then I'm going to make a insulin bolus calculation based on that number. And if that number is off, I can end up with hypoglycemia or hyperglycemia. That's the first problem. I also tell patients that how they prepare their food is really important, because there are things that change with the structure of a starch, for example, right? Whether it's cold or hot or even reheated, is going to determine what the glycemic impact. And I saw one study that talked about pasta, and it found that reheated pasta was going to not, had lower blood glucose level fluctuations versus something cold or hot. So I think understanding what the food is and how it impacts you makes a difference as well. And then I think also when you're consuming carbs, so you'll see a number, and then but are you consuming that with fat or protein? I saw one of your older videos where you talked about, I think you compared some type of candy or protein bar with a banana, right?
Right.
And I think in that video, you highlighted that maybe the reason why the banana lost the battle, and had higher blood sugar rises, because the bar had protein and fat, right? So if you combine a carb with protein and fat, it blunts the rise. So I guess what I'm getting at is, if you don't factor in all of these factors, rather is what the FDA allows in terms of your carb number to be or not, then you'll give yourself insulin and you don't even know what you're doing. Therefore, a type 1 diabetic in particular has to be a little bit smarter, a little bit more educated about what they're consuming. And I think the best experiment, Dennis, is the experiment at N of 1. You have to try things. That's why I like your channel, because you do the experiment. Let's see what happens when Mike the meter, is asked to give us an opinion. And I think that those are the types of things that people have to do individually. So you take the big picture knowledge and then you apply it to yourself, and you don't really judge it until you see how your body reacts.
Yeah, when I first started having blood sugar problems and started using a glucose meter to figure some things out, I didn't really count carbs. I just checked with my meter and did the postprandial tests. And after a while, I began to see that foods that had higher carbs, they spiked me higher. And after a while, I would look at the carbs and say, well, I can't do that. I know what Mike the meter is going to say if I eat that food. Another one might be low. And I say, well, that'll work. So yeah, I started out not really counting carbs. And even today, I don't count them much. I do once in a while. If I see something that's got high carbs, I'll say, well, that's as much as 2 candy bars. I don't care how healthy it is.
That's right.
In other cases, I will, look at the numbers. But in some cases, I just Mike won't like that. There's no use me even trying.
That's right. That's right.
So, all right. Well, all this sounds pretty complicated, but for those that want to figure out what do I actually do to get the numbers down, type 1 is what we're talking about mostly today, but we can even throw in the type 2s. When you're high, specifically, what do you do?
Yeah, and I'm glad you mentioned type 2s. Everything that we talk about for type 1s applies to type 2s. And I think anybody that follows you on your channel or on my channel know that the first solution is get rid of the poison. So I think for anybody who wants to reduce glycemic variability and wants to get the kind of control they want, let's stop consuming the poison. So we're going to reduce the amount of carbs we consume. And that's number 1. So we're going to go on a low carb keto diet, ketovore, whatever suits you. We're also going to be very astute. So we're going to do our experiment N of 1, where we make sure that we properly dose our insulin. And I think that's going to be number 2. And number 3, one of the things, with my NEST acronym, with nutrition, exercise, less stress, more sleep, that reminds me and my patients what they need to focus on. So the E is for exercise. And I think it's important that, and a lot of people should just start with walking, but what you want to do is get on a regular cadence. One of the biggest principles here is not over exercise. And when you do exercise, do something that's fairly predictable. That way you can kind of tweak your meals to fit, and you can, because if you exercise, you may need less insulin. So you want to factor that in. You got to be so if I'm jogging, I may do something different than a walk. The S in my NEST talks about sleep. So sleep is critical because it does a lot of good things. We know insulin type 2 is insulin resist, insulin resistance, but even there's a level of insulin sensitivity you want to have. And when you're getting more sleep, that improves. You want to reduce cravings. And when you're not having to consume a ton of insulin and you're sleeping well, that'll go down. And just your metabolic health improves overall. So what I tell patients, you got to get your sleep right. You do that I use blue blockers at night. So I look like, my wife laughs at me every night because I'm walking around with these dark shades on, like, I'm singing a song or something. And number one, so I do that. I'm on a regular schedule. We fuss about the temperature, but I try to keep it cool as possible. I sometimes cover my eyes with some type of cover so it's darker. And I try to avoid caffeine, at least 8 hours before I go to sleep. And I also make sure I get light during the day. So I want people to optimize their sleep, particularly if you're type 1, but that applies to type 2. And I got to break your heart on this one, Dennis. Alcohol, right? A lot of people we know and love want to have a nice, wine at the end of the day. And again, for a lot of people, it's not a big deal, but alcohol does cause something called hypoglycemic unawareness. So it is possible that alcohol can make you unaware that your blood sugar is low, and that's not a good thing. It also can causes, problems with your glucose recovery. So when you're trying to get your sugars back up, it can be delayed a little bit. And just in general, the risk of alcohol causing hypoglycemia, and in some cases, hyperglycemia is a problem. And as you know, diabetes can increase your risk for neuropathy with the nerve problems. Well, alcohol can do the same. So if you put those two things together, you can have a problem. So for people who are wanting to get an A1C in the 5 range, in the normal range, it's probably best to minimize or avoid alcohol altogether. And the last thing I think about, which is so obvious, is smoking. It is really important that when you're trying to become metabolically healthy, that you don't smoke, because what they found in studies is that smoking does impact glycemic control negatively, and it increases your risk for like retinopathy and of course kidney failure. So I tell my patients, let's not introduce poisons into our body. And poisons are not just carbs. Sometimes it's, too much alcohol, and sometimes it's smoking. So with these, so the big message for me is that you can't fix your diabetes, particularly type 1s, with just insulin. If you have to think about these other factors, and if you factor in all of these other factors and do an experiment over the course of a year, by the end of a year, you'll optimize yourself so that you can get the type of control. And yes, I have patients who are type 1 diabetics with A1Cs in the 5 range.
Wow, that is great. Well, there's one question that's kind of burning on my mind that I wanted to put to you, and that is a kind of a hypothetical situation. A patient comes to you, and he's in fairly good shape, fairly lean, but he tends to spike a lot, and he eats a fairly high carb, low fat diet. He thinks that's the healthy thing. His A1C is decent. Let's say it's 5.4. His fasting glucose is around 100. So by normal means, he's not diabetic, but he tends to spike up toward not too far from 200, and then he plunges down. Now, he may say to you, look, doc, my A1C is good. My fasting glucose is good. Yeah, I spike a bit, but I mean, I feel great. There's no harm to this, right? I'm not in any danger, am I? What would you say to somebody who spikes a lot, but they've got the decent A1C and the decent fasting glucose?
Everything I think about in my work is big picture, 30,000 feet in the air, like I'm on a plane ride, right? And so we know that hyperglycemia can cause damage. I mean, because it's going to lead to some insulin spiking. And we know that insulin, it just by itself, excessively spiking over time can cause inflammation. And we already know that most chronic diseases, stroke, heart attack, dementia, is called type 3 diabetes. Cancer cells love sugar. So why would I want to have all of this hypoglycemia leading to metabolic syndrome? I call myself the metabolic, health doc, because I think it's the root cause of 80 of all chronic illnesses. So what I would say to a person like that, if you have a parameter that's off, and that would be postprandial after meal blood sugars, you should still be concerned. And I'm going to tell you why. What I tell patients is the following. In Chicago, we have streets that sometimes require salt, and that salt leads to potholes. Those potholes, cars get stuck because the potholes exist. If the potholes didn't exist, the cars wouldn't get stuck. Well, the same thing occurs in our arteries, but instead of being salt as the problem, is the blood sugar being high. And so even if it's not as high as we thought it, would be in terms of harm, it's still going to cause potholes in your arteries. Well, what gets stuck in your arteries when you have potholes? The cholesterol. And the cholesterol will then, it's going to try to just patch it over nicely and smoothly. But if there's inflammation because of all of those spikes, it's going to then build up and cause increased risk for arteries getting clogged, not just in your heart, in your brain, in your legs, around your kidneys. So I think that over the course of a lifetime, a person who's spiking like that is going to be at risk for those potholes, leading to cardiovascular disease and leading to all of those metabolic conditions that I think can harm us. So I think it's best to not spike and to come up with a way to not eat foods that won't cause those spikes, low glycemic foods, low carb foods, and things like that. And I think that he'd be better served to do it that way.
Yeah. Well, I have a feel most people wouldn't know whether they spike or not, because unless they're officially diagnosed as diabetic, they're not going to have that checked. They're not going to ever test themselves with a blood sugar meter. So they don't know. I have a feeling that if we took all of America and gave them blood sugar tests, let's say every adult over 21 years of age, probably the majority of them would spike far higher than they need to.
And I would say let's fix that by doing two things. One is everybody should get a fasting insulin level. So at least you'll know, is my insulin level, is my pancreas working harder than it should be because of all of these spikes? Because eventually it's going to get tired of all of those spikes, right? Yeah. So that's number one. And the fasting insulin level is easy to get. If your doctor won't order it, then you can probably figure out how to do it. There's companies that'll let you get it. And it'll predict diabetes 5 to 10 years in advance, which is amazing. And then the other thing, which is even more amazing, is a coronary artery calcium score test. Because why do we care about all this in the first place? We care about it because we know diabetics or people with diabetes have the same risk for a heart attack as a person who's had a heart attack, which is very difficult to hear. However, if we can look at our arteries and see, do we have plaques or calcium built up already? And if the answer is no, then at least we could, slow down and have more time to figure this out. So I would ask people who are not sure, borderline or not, get a calcium score, get an insulin level, and you'll really do yourself a favor. You can predict diabetes and future heart attacks with those two tests.
Well, that's great advice. As you were talking about how people are forcing their pancreas to work too hard and eventually something's going to give, it reminded me of a situation with one of my computers that I use a lot in my house. When a computer is overworking, playing a video that it can't hardly handle, the fan goes into high gear and you hear that fan really trying hard to cool everything down. I had one of my computers was just like that. And I'm like, this thing isn't going to last much longer, because anytime I play a video at any kind of high resolution, that fan just goes crazy trying to cool everything down. So it's like, it's time for another one. But we don't have any choice about getting another pancreas or another body. So we just need to kind of cool things down to make our pancreas not have to work like those computer fans do. So thanks.
If we ignore that fan, it's not going to go away. Yeah. It's like you have to face that's the reality we have. So Houston, we have a problem, and let's address the problem before it becomes a bigger problem. The good news about what we're talking about, this is about healing and reversing disease. So don't let that scare you. Say, oh my God, I just heard a nice video with Dennis and Dr. Tony, and there's a way to fix this. So I don't have to be afraid to take my computer in to get it checked.